Lenalidomide is a very active drug in several different types of malignancies. Lenalidomide, as we know, is commonly used in the treatment of myeloma. And about 8 to 10 years ago at MD Anderson, we began exploring combinations of lenalidomide and rituximab in low-grade lymphomas. And this was based upon preclinical data that we had done at our center, suggesting that there was synergy between lenalidomide and rituximab. The idea was that lenalidomide, which had been shown to augment the activity of certain types of immune effector cells, NK cells and T cells, could potentially synergize with a monoclonal antibody like rituximab and increase ADCC, antibody-dependent cellular cytotoxicity. In essence, augment the effect of rituximab in low-grade lymphomas. We designed a very early pilot trial looking at this combination in untreated follicular lymphoma patients. We enrolled 30 patients. And actually in low-grade lymphomas, we saw very high responses. 98% of patients responded to the combination. Now, after that trial was announced, there were other trials which were initiated and were also reported showing very similar overall response rates and complete response rates with the same regimen in the same population of patients, follicular lymphoma patients. This group of trials, our trial as well as other subsequent trials, then led to a randomized phase 3 trial called the Relevance Trial. And this was a trial which was recently completed, which looked at lenalidomide and rituximab versus rituximab plus chemotherapy in patients with follicular lymphoma. This was the Relevance Trial. It enrolled 1,000 patients, and we may actually see data from this trial soon, which will look at this new regimen for patients with newly diagnosed follicular lymphomas.
The MAGNIFY study showed the use of lenalidomide and rituximab in patients that have relapsed and refractory follicular lymphoma. This was really interesting because they actually also looked at a subset of patients that were double refractory to either an alkylator or rituximab or early relapse. And this was presented at ASCO this year. What they demonstrated was that the regimen seems promising, that had high response rates, but in the early relapse population, there was also evidence of a signal of efficacy, suggesting that about 50 to 60% of patients responded and the duration of response was about 1 year. So I think that in this particular population of patients might have a promising future. The phase 3 Augment study is looking at lenalidomide and rituximab compared to rituximab placebo in patients with relapsed follicular lymphoma. That study is still ongoing, and what they're looking to evaluate is whether or not lenalidomide is an important addition to rituximab in the treatment of patients with follicular lymphoma. I actually have used lenalidomide and rituximab in patients with relapsed indolent lymphomas, and I find that it is well tolerated. The benefit of it, too, is that you can modify the dose based on cytopenias and side effects such as rash or fatigue or myalgias that the patients might experience. But I find that the duration of response is actually quite good. Particularly with elderly patients, I find that it's very easy to administer, so we certainly do use it quite a bit in patients with relapsed indolent lymphomas.